Hi class, in this lecture we will discuss drug therapy options for treating high cholesterol and triglycerides. Here are some vocabulary terms you should be familiar with. Please check your textbook for definitions. The objectives are listed on the slide and they're also listed in the Blackboard module. So let's begin with a quick pathophysiology review. If you haven't watched the short video that's posted in the module, please do so now. It provides an overview of atherosclerosis. You all should have watched the pre-work video, describes how atherosclerosis occurs. Atherosclerosis is also called ASCVD. This is the abbreviation you're probably all familiar with. You'll hear it all the time. In ASCVD, we're concerned because we have thickening of the coronary arteries. And that thickening of the coronary arteries, as you saw in the video, can lead to all kinds of issues. Basic issues like chest pain because of lack of blood flow, but if the blood flow is occluded enough, that could cause a myocardial infarction or even stroke. So the reason why we talk about cholesterol is because the risk for developing ASCVD is directly correlated to the blood cholesterol level, specifically LDL, which is low density lipoproteins, and we'll talk about those in a moment. Lowering LDL can slow cardiovascular disease progression and reduce the risk for mortality. So what is cholesterol? Basically, it's an endogenous substance. It's very important for numerous functions in the body. Cholesterol is a lipid. It is an essential component of cell membranes. It's required for the synthesis of hormones and bile salts, and think of how important both of those substances are. It also reduces water evaporation on the skin. Another type of lipid that's important are triglycerides, and they are made from fatty acids and glycerol, and they provide energy storage, and in times of need of energy, that energy can be released from those fatty acids. So if you look at the picture on the screen, what you see there is a plasma lipoprotein, and lipoproteins are what carry triglycerides and cholesterol through the bloodstream. Since lipids are not charged, they're not soluble in water or blood, and so that's why we need these lipoproteins. So lipoproteins carry, I already said, cholesterol and triglycerides through the blood. So I want you to think for a moment, what are the three most important lipoproteins that you've all heard of? I've already mentioned one of them. So I don't know, pause the tape for a second, see what you can come up with. Okay, so if you said LDL, that's probably, the one that we talk the most about. LDL is low density lipoprotein. LDL has the greatest contribution to atherosclerosis. LDLs carry cholesterol from the liver to other parts of the body. And so that's why we want to lower LDLs. Other lipid proteins that you may have come up with, HDL. So HDL is high density lipoprotein, and HDL carries cholesterol back to the liver. So you guys might remember HDL is called our good cholesterol because HDL is actually removing cholesterol from the systemic circulation, bringing that cholesterol back to the liver, and so that's why we call it the good cholesterol. The other one you may have heard of is VLDL. VLDL is very low density lipoproteins. It's a little unclear whether or not these contribute specifically to atherosclerosis, but they do carry triglycerides, and they definitely have a role in pancreatitis. So all in all, cholesterol is important. We worry about cholesterol again because of its role in atherosclerosis. And from a drug therapy standpoint, some of our most effective drugs are drugs that reduce cholesterol. Let's move on and discuss the pharmacology of medications used for cholesterol management. So first, very briefly, we can talk about the approach to treatment for these patients. Management of cholesterol, high cholesterol, begins with screening. So we usually screen patients every 5 years after the age of 20. Depending on their risk factors, might be more frequently. Guidelines for kids are a little different. You can look in your textbook. There's a full discussion on this. I just want to warn you, we are not going to test you on that. But if you are interested in how these patients are treated, how we identify that they've got high cholesterol, kind of what's recommended, how we risk stratify the patients, you can take a look at that. One thing I definitely want to point out when we do treat patients who are either at risk for ASCVD or for, of course, those patients who have ASCVD, one very important component is lifestyle modifications. So these are non-drug measures that can actually lower LDL, and they of course can have an impact on the patient's ASCVD risk. So for example, encouraging regular physical activity or exercise, eating a diet that is designed to reduce cholesterol, for example, lowering saturated fat intake, increasing soluble fiber and plant stanols, things like that. Weight control, of course. So, obviously diet and exercise will play into weight control, but also smoking cessation. As you saw, toxins can increase the risk of ASCVD from that video, that pre-work video. So smoking cessation is an important component as well. Now, medications in many cases will be required, probably in almost all cases will be required. And so for patients who are on medications, adherence is of critical importance. Medications for cholesterol lowering are lifelong. These are not medications that you can take for a few months and then your cholesterol is permanently lowered. These medications will be on board in almost all cases lifelong. Now, is it possible that a patient could totally dramatically change their lifestyle and that will, cause their LDLs to go down to a level where we may not need therapy? Sure, that's possible. It's just not the scenario that we see most commonly. So these are the medications. We have the HMG-CoA reductase inhibitors, also known as the statins. Cholesterol absorption inhibitor, there's only one drug in that class. Bile acid sequestrants, niacin, fibrates, those two are older drug classes, not used quite as frequently anymore. And then we have some other options like the subcutaneous therapies. These are all very new drugs on the market, very costly, but they're very effective. And then we also have an over-the-counter product, omega-3 fatty acid. I should say actually a complementary and alternative medication, which is available, in drugstores. And there's also a prescription version of that as well. We're going to start with the HMG-CoA reductase inhibitors. Our prototype statin, so I'm not going to say HMG-CoA reductase inhibitor throughout the lecture. I'll just call them statins. That's what everybody calls them, because all of the drugs in this class end with the word statin. Just to point one thing out, there are a couple drugs out there that end in statin that aren't actually statins, like a nystatin. That's actually an antifungal agent. But for the most part, if you see statin, it's probably a good safe bet that it's an HMG-CoA reductase inhibitor. These drugs work by inhibiting HMG-CoA reductase enzyme. This is the rate-limiting enzyme in the production of endogenous cholesterol. P.S. The majority of cholesterol in our body comes from endogenous production. Most of it does not come from our diet. So you can imagine that targeting endogenous production of cholesterol would be a good way to reduce cholesterol. This drug is used for high cholesterol or hypercholesterolemia. And when we think of patients with hypercholesterolemia, we think of either we're trying to prevent cardiovascular events before they happen, so we call that primary prevention, or we're thinking of patients who have already had cardiovascular events and we're trying to prevent future events, so secondary prevention, right? In the first example, primary prevention may be somebody with diabetes, they're at risk for cardiovascular events, and maybe their cholesterol is not really, necessarily elevated to, high levels, but we don't want them, they're at a higher risk for these cardiovascular events. And then the other group example would be patients who have survived an MI. They've already had a cardiovascular event, so for those patients, it would be secondary prevention. These drugs have been shown to slow the progression of ASCVD, decrease the risk of stroke, hospitalization, cardiac events, peripheral vascular disease, death. This has been seen in men, women, healthy people with no previous cardiovascular history. These are intensely studied medications. So who do we worry about? Well, first of all, because of the role of cholesterol throughout the body, we do worry about pregnant patients. So patients who are pregnant, we don't use these medications, or in fact any of the cholesterol medications, because the risk to the fetus outweighs the potential benefit. So they're just not used in pregnancy. The idea is if the patient is pregnant and they've got high cholesterol, going off the medications for the duration of the pregnancy, that risk is reasonable, given the risk to the fetus could outweigh the potential risk to the patient in that short-term time frame. We also avoid these drugs in patients with hepatitis because they are metabolized by the liver, they work in the liver, and they can actually cause hepatitis, so they could cause a worsening of liver dysfunction. So patients with severe liver dysfunction, these would not be used in. Generally speaking, these drugs are very well tolerated. And so I say that, but in the same breath, I'm going to say to you that over half of patients who start these medications stop them within a year. So they're well tolerated, but they do have some annoying side effects that will cause people to stop the medications. So they can cause some GI issues. And the GI issues can be a problem. Usually those subside after, the patient's on the medication for a little while. They have been associated with new onset diabetes. The exact mechanism of this is unknown. There's a lot of kind of research into this area right now. It's thought that the drugs themselves don't necessarily cause diabetes, but possibly, thinking about the population of patients we're using these drugs in, maybe they're pre-diabetic, maybe they're, patients that already have kind of a metabolic syndrome going on, and these drugs can potentially unmask that diabetes a little sooner. That's kind of the kind of going thinking on that. Myopathy is really the big issue that is probably the biggest concern, probably one of the main reasons why patients stop these medications. So myopathies, myalgias. So myopathy is just muscle pain. Myalgias would be pain, but not elevated creatine kinase. So myalgia would be inflammation, again, pain, inflammation, but no CK elevation. And then myositis, which is actual inflammation with CK elevations, which can be dangerous, can lead to rhabdomyolysis, can lead to renal failure. It's very rare. It is, not something that is seen frequently at all. I can say, though, that myopathy is reported. The true incidence of myopathy isn't really known. It's thought that it's, at least from studies, it's around, observational studies around 15%, clinical trials maybe as low as 5%. But patients do complain about muscle pain when they're on these medications. So it's something to tell patients about, have them look out for, just because it can progress to something more serious. There are lots of things we can do. If they get myopathy, we can change them to a different drug. Usually, if the drug is stopped, the myopathy will stop. The serious forms of this can stop as well, depending on how early we detect them. They might get put on a different drug. They might try a different schedule. There are things that can be done. So you want to tell patients, about this possibility, but also tell them it's not necessarily a reason to stop the medication. It's just a reason to talk to your prescriber and figure out what you can do differently. Another potential concern, is liver injury. This is very rare. So when I say liver toxicity, actual toxicity to the point where the patient's jaundiced, and potentially could have liver failure. This is very, very rare, but it does happen. Now, with that said, some patients will have mild elevations in their serum transaminases, but generally, it's inconsequential. But again, it's still something that you do need to tell the patient about, so that they can look out for symptoms and they can be evaluated, so that if they are one of those patients that will progress to full-on liver injury, we catch them early. These drugs are oral medications. They are available as combination products. So they are combined with other cholesterol medications. So there is the risk there for kind of confusion with the different products. So keep that in mind. Some drug interactions. Drug interactions are a big deal with the HMG-CoA reductase inhibitors. In fact, when I talked about some of the side effects, we see those side effects more likely when there are drug interactions. And so again, going back to if we manage those issues up front, then the patient's not going to have adverse effects and they won't discontinue their medications. So these drugs are metabolized by P450. And so any inhibitors that affect the metabolism of these drugs, like protease inhibitors or grapefruit juice, these can be a big deal and can increase levels of these drugs, and that leads to an increased risk of problems like myopathy, especially myopathy. When these drugs are used together with other cholesterol drugs like niacin or the fibrates, that can increase the risk for myopathy and even liver toxicity. And this just has to do with, to some extent drug interactions, but especially around that liver toxicity, it just has to do with they all affect the liver. And so multiple drugs on board that can affect the liver increases the risk for liver toxicity. So let's talk about some nursing implications. It's recommended that these drugs are given in the evening. That's a common NCLEX question, so something that you want to highlight. Does it mean they can only be given in the evening? Probably not, especially the newer agents like atorvastatin or rosuvastatin. These drugs are very potent. They can probably be given at any point in the day. The reason why we say in the evening is because cholesterol synthesis is usually mostly happening overnight when the patient's asleep. So that's why if we give the drugs in the evening and they're at their highest concentrations, then we've got more suppression of HMG-CoA reductase. Other things, we do monitor baseline creatinine kinase and liver function, but we don't monitor them serially. So we don't monitor them every 2 months, every 3 months, every 6 months. Like in the old days, we used to do that. Nowadays, we really just do an upfront monitoring. And then if the patient's having symptoms, depending on how severe they are, then we might also monitor those tests again. Educating patients about signs and symptoms of hepatic dysfunction and myopathy is very important. These patients may not be in the hospital, they may be home in the ambulatory setting. If they're having those symptoms, you want them to call their provider for 2 reasons. One, you don't want them to stop the medication. So if they call the provider and they can be evaluated to figure out why that's occurring, and maybe some tweak to their medication regimen can occur, and that will allow them to continue on the medication. So that's probably the most important reason. Secondarily, though, if they are one of those patients that will progress to a more serious form of either of those conditions, we want them to be monitored, and we want to, catch that before it gets very bad. Finally, since these patients are taking medications that are metabolized by the liver, it is a good idea generally to avoid alcohol. One last thing to talk about with the HMG-CoA reductase inhibitors is name recognition. I mentioned this at the start, but statins, generally we call the HMG-CoA reductase inhibitors statins, and all of these drugs will end in statin. So these are some of the examples that are listed on the slide. There are a couple other drugs, like I mentioned, nystatin is not a statin. It's actually an antifungal agent. So occasionally you might come across other drugs that aren't statins, but for the most part you see statin. It's a pretty good assumption that it's a cholesterol lowering medication. The next important medication is the cholesterol absorption inhibitor. There's only one drug in this class currently, ezetimibe or Zetia. This drug is important because it's really our second-line drug. So when patients are maxed out on their statin, or maybe they don't tolerate a statin, but they've still got elevated cholesterol or elevated risk, the next thing we do is prescribe them a Zetia if they're a candidate for Zetia. These drugs work by inhibiting absorption of dietary cholesterol, and they also prevent reabsorption of cholesterol from the bile. And so essentially, they help to increase the amount of cholesterol that's excreted, right? They're used for hypercholesterolemia, either patients with high cholesterol, or again, it could be patients where we're doing primary or secondary prevention, but again, their cholesterol is not lowered to a level that's sufficient for that primary or secondary prevention, and so we would add on Zetia. We rarely use this as a first line agent. If it is used first line, it would be because there's a reason why the patient can't take a statin. Individual variation. So again, we don't use these drugs in pregnancy just because of their effects on cholesterol in the developing fetus. And then also these drugs are affected by liver dysfunction. So that would be another group of patients where these may not be appropriate. Overall, again, extremely well tolerated. I mean, really, these drugs, of all the drugs we talk about today, these are the boring drugs. There's really nothing to talk about because they're just so well tolerated. They can cause some diarrhea. They can cause liver problems or muscle problems, but it's not common. Maybe, if they're used concomitantly with other medications like statins, which, is generally how they're used, and there's already a pre-existing problem, possibly, but generally speaking, they don't really cause problems. So some nursing implications, again, avoiding alcohol, doing those baseline tests, creatinine kinase, liver function, educating patients about symptoms of hepatic dysfunction. The next class of drugs are the bile acid sequestrants. Our prototype is Cosevalam or Welchol. These drugs work by their effects on bile. Bile is secreted by the liver into the GI tract, and it contains cholesterol, and bile acids themselves are made from cholesterol. 95% of the cholesterol from these sources is reabsorbed into the intestines. So these bile acid sequestrants will actually bind to bile acids and prevent them from being reabsorbed, and this is what helps to decrease circulating cholesterol. They also stimulate the liver to remove LDL from the blood to make more bile acids because they're sequestering bile acids in the intestines. Obviously, they're used for high cholesterol. These drugs are biologically inert. So what that means is the only thing they do is bind to other substances. So they, for example, bind to bile acids, but the drugs themselves do not get absorbed into the bloodstream. They stay in the GI tract. They're available as tablets. They're also available as packets that have granules, and you pour the granules into some form of liquid, and they dissolve, and then the patient can drink the liquid. Some individual variation to think about. Bowel obstruction. I think that makes sense, right? So bowel obstruction, there's issues going on in the bowel. These drugs are going to stay in the bowel. They're going to potentially make things worse. Additionally, pancreatitis due to high triglycerides. Again, because of the way these work, they can have some effects there as well. So adverse effects. These drugs, of all the drugs we talk about, these are the drugs that patients really don't like being on. They cause a lot of GI discomfort, constipation, bloating, indigestion, nausea, and these are real things that happen that don't necessarily go away. Sometimes if the medication is given along with meals, that can help, but a lot of patients will still complain of those abdominal issues. Lots of drug interactions. If you know nothing else about these drugs, please know that they cause drug interactions. They're essentially absorption interactions. So these drugs bind with other drugs and prevent those drugs from being absorbed. That's a big deal, especially for nurses. Remember, pharmacists probably aren't paying attention very closely to the absorption interactions. The prescribers probably aren't paying close attention. They're going to expect that you as the nurse who's administering the medication is making sure not to administer it with other medications where absorption could be a problem. So you have to know this. This is absolutely crucial. Give other meds either 1 hour before the bile acid sequestrant or 4 hours after the bile acid sequestrant. I mentioned that this drug is available as either granules or a tablet. If the granules need to be mixed with an adequate amount of fluid, otherwise it can irritate the esophagus. And encourage these patients to take this medicine with food. One, because it can help relieve some of those GI problems, but also they can have constipation. So plenty of fluids, plenty of water. Increasing dietary fiber can be helpful, or even using a mild laxative. The next drug is niacin. Niacin is a drug, it's been around for a very long time. The brand names are Niaspan and Niacor. It's actually also available as a complementary and alternative product. It's actually a vitamin. This drug is thought to inhibit triglyceride synthesis, and it can decrease LDL levels, and it also can have modest increases on HDL. And it's not entirely clear how the drug works, but it does have these effects. It's used mostly as a third or fourth line agent. It's rarely used as a first line agent. I would say actually it's never used as a first line agent. If patients have both high triglycerides and high LDL, it can be a drug that would be considered. Or maybe, it could be used for low HDL. So again, this drug can increase HDL, so it could be used to just increase low HDL levels. Or again, if the patient has high triglycerides. That's really kind of where this drug has its biggest niche. If high triglycerides is one of the spots, but it also increases HDL better than any other drug. So if a patient has low HDL, that's kind of a niche for this drug. Dosage forms. So this is important. It's available either immediate release or extended release, and there are differences between the dosing of the different forms and risks that are associated with those different forms. Some individual variation. Part of why this drug is not used a lot is because it actually causes a lot of problems. It is, so for patients who have liver dysfunction, active liver disease, this drug cannot be used. It affects the liver. It also can precipitate gout. So for patients that have gout, especially active gout, this drug is not a good idea. It will make that situation worse. Patients with diabetes, it could worsen glucose control, increase insulin resistance. So, we try to avoid this drug in those patients as well. One of the biggest issues with this drug, though, is that it causes flushing of the face, neck, and ears. And this is real. I've seen this personally numerous occasions. I know I always tell you guys stories about my husband, but he's on niacin and he hates it. He, will wake up in the middle of the night out of nowhere. He took the drug hours and hours and hours prior, and he's got this intense flushing all over his body. Generally, it happens around the time the dose is taken, but it can happen at any point. One thing that we do is tell patients to take aspirin about 30 minutes prior to their niacin dose, and that can prevent some of that flushing. It's very, very uncomfortable for patients, that flushing reaction. It can also cause liver toxicity, as I said. It can elevate uric acid levels. It can, cause changes in glucose control, and then, of course, GI distress. So this drug is just not well tolerated. It's not a drug that's even highly effective, so it's not a drug that we use all that frequently. Nursing implications. Obviously, lots of nursing implications. Anytime a drug causes problems, there's going to be lots of nursing implications. So administering aspirin before the niacin dose, ensuring patients drink a lot of water. This can help with uric acid excretion. Monitoring, so blood glucose, uric acid, renal function, hepatic function, advising patients to avoid alcohol because of its effects on the liver. And this drug can be taken with food to prevent some GI issues. And I want to reiterate those dosage form problems. So because there are multiple different types of niacin available, it's easy to get those mixed up. The immediate release form is given 3 times a day. The extended release is given once a day at bedtime. And then niacin itself, also known as vitamin B3, is available over the counter. The doses, the tablet doses are much smaller, but some patients might think it's cheaper to use that version versus what they've been prescribed. There's just a lot of potential issues around this drug and things to think about. The next drug class are the fibrates. Our prototype is gemfibrozil or Lopid, which is the brand name. There are a few drugs in this class. I doubt you'll see these drugs all that frequently, just because they are associated with a lot of problems, a lot of drug interactions, a lot of adverse effects, a lot of different patients that aren't good candidates for these drugs. So I don't think you'll see them, but because of all the issues with the drugs, I think it is a good idea that we're talking about them in case you do see these medications. These medications bind to the liver to accelerate clearance of VLDL, so very low density lipoproteins, which basically means triglycerides, and they also increase HDL production. Primarily, they're used for patients with high triglycerides. Now, statins, which we've already talked about, they are able to reduce triglycerides, so those are still the first line treatment. But if the patient doesn't have adequate reduction, then this is a drug that might get added. Or if for some reason the patient can't be on a statin, then this is a drug they might use. So some issues, there are several contraindications. So in severe liver dysfunction, severe kidney dysfunction, and especially gallbladder disease, this drug can be a very big problem in patients that are predisposed for gallbladder disease. So adverse effects, of course, like many of our other cholesterol drugs, they cause GI problems, nausea, vomiting, diarrhea, and then gallstones. So as I said, this drug is not used in patients that have a history of gallbladder disease. Basically, they increase the cholesterol content of the bile, and that increases the risk for gallstones. They can also cause myopathies. They can also cause liver problems. So hopefully you've started to see a trend here. All of the drug classes we talked about potentially cause liver toxicity, and that's because that's where they work. They work in the liver, essentially influencing either liver cholesterol production or reabsorption and so forth. And then this drug can also cause myopathy. So like some of the other classes we've talked about, like the statins, they can cause myopathy, as well as Zetia. Zetia also could cause myopathy. So drug interactions are a big deal with fibrates. So when you encounter a patient on a fibrate, you need to be thinking whether or not they have any significant drug interactions. I'm only listing 2 on the slides, but you should know there are lots. Of all of the cholesterol drugs, the fibrates and the statins are the ones we worry about with regards to metabolic issues and metabolic drug interactions. But then, of course, we also worry about some of the other drug classes as well. But this class in particular, very concerning. So when they're used along with statins, they increase the risk of myopathy. And that's, again, because they both can cause that side effect. They also are very worrisome when they are used in patients on warfarin. These drugs displace warfarin from plasma albumin. So you may remember in the beginning of the course, we talked about patients that, drugs that have affinity for albumin. And so if they have a high affinity for albumin and another drug comes along and bumps them off the binding site, there can be some issue there. So in combination with warfarin, these drugs can be a problem. They can increase warfarin exposure, increase the INR, and that would increase the risk of bleeding. So again, lots of nursing implications. So these drugs are administered usually 30 minutes prior to breakfast and dinner. You need to instruct patients to watch for symptoms of gallstones. So right upper abdominal pain, intolerance to fatty foods, bloating. These are good signs and symptoms that the patient might be having gallstones. Monitor liver function tests. And so this is done at baseline as well as throughout therapy. So unlike some of our other drugs, we do serially monitor liver function tests, advising patients to watch out for symptoms of myopathy. Of course, for all of these things, if they're having symptoms, they need to contact their provider. Finally, if the patient's on warfarin, then they should have a closer follow-up of their PT-INR. Finally, let's talk about some of those other agents that, well, some of which are starting to become more popular. And then, of course, the CAM product, omega-3 fatty acid. So let's talk about the subcutaneous therapies first. Probably the one that I think you're actually going to see, maybe not so much now, but maybe in a few years, are the PCSK9 inhibitors, evolocumab or Repatha. This drug is a monoclonal antibody. It creates more receptors on the liver to absorb cholesterol from the blood. It is highly effective. So when this drug is added to a patient already on statins, the relative risk reduction in ASCVD is actually quite significant. So these drugs do have a place in therapy. The problem with these drugs is that they're very expensive. So getting them covered and, issues around access, that's really why we don't see these drugs used all that frequently right now. But because they're so effective, I think in the future we will start to see these more and more. Right now, they're approved for homozygous familial hypercholesterolemia. So these are patients that have a genetic disorder that causes them to have very high cholesterol. And because of that, they have early ASCVD. So it's very important for these patients to have appropriate drug therapy. So this is a medication that in that population would definitely be something we'd see. For primary hypercholesterolemia, so that means other patients, not familial hypercholesterolemia patients, but just any patient with high cholesterol. The newest guidelines do have these drugs, specifically the PCSK9 inhibitors, specifically indicated as add-on therapy to statins when the statins don't decrease the cholesterol sufficiently. So I expect over time we're going to start to see these drugs more and more. The other drug is the antisense oligonucleotide. It's mipomersen, Kynamro. Some of you may have heard of it. It inhibits synthesis of apolipoprotein B. It is, again, approved for homozygous familial hypercholesterolemia, and that really is the only use. This is not a drug that you'll see kind of just in the general population. They're both sub-Q therapies. So both of these drugs are administered sub-Q. Depending on the drug, some are given every week, some are given every few weeks. We haven't included that level of detail, but understand the patient needs to know how to prepare it. If it's a powder, how do they reconstitute it? How do they give themselves a sub-Q injection? How frequently should they inject? So again, some of these are given every week, some are given, less frequently than that. So making sure the patient understands those variables. Also, Kynamro or mipomersen, that drug can cause liver toxicity. In fact, there's a black box warning about liver toxicity. So that drug should not be taken with other drugs that can cause toxicity to the liver. So for example, Tylenol or acetaminophen. So you have to talk to patients about signs and symptoms of liver toxicity. Now we've gone through those again and again. So if you don't know what they are, make sure you go back and review some of your past lectures. Now just to mention, so I have a little note, there's a chance that, especially the PCSK9 inhibitor, evolocumab, there's a chance that could be on your NCLEX. I doubt Kynamro will be because that drug really has a very isolated use. But we are not, as of right now, we are not going to test you on the PCSK9 inhibitors. But it could be on your NCLEX. Finally, omega-3 fatty acids or fish oil. This will be on our exam, trust me. This drug works by reducing the production of VLDLs in the liver. It is a combination of two different fatty acids, DHA, which is docosahexaenoic acid, and EPA, or eicosapentaenoic pentenic acid. Sorry about that mispronunciation. Much easier to say EPA and DHA. These are heart healthy compounds. They are found in fish oil. The medication itself is formulated as a complementary product or a dietary supplement, which is available, over the counter in a pharmacy or even a nutrition store. Or there is a prescription version. So there is a prescription omega-3 fatty acid. The brand name is Lovaza. And really, if these drugs are used, well, let me rephrase. So a lot of patients use these medications. They're over the counter. They're for the most part very well tolerated. It's kind of a trendy thing to take these medications. A lot of primary care providers actually prescribe them, and patients can just walk into the grocery store and pick them up off the shelves. The prescription, however, that one I don't think you're going to see a whole lot. If you do, it will be because a patient has high triglycerides, and insurance companies probably aren't paying for this, but if they've got high triglycerides, then it's something you could see. Adverse effects, just kind of some GI issues, diarrhea, nausea, belching, dysgeusia is kind of like a weird taste in your mouth. Drug interactions. This drug can potentially increase bleeding risk, so we are we were cautious with anticoagulants or antiplatelet agents. One thing to keep in mind is this is a capsule, and it has kind of like a liquid or a gel inside the capsule, but it is quite large. And so patients can have some difficulty swallowing it, but you can't break it. You can't open it. It's not something they can cut and pour into liquid. They do need to swallow the capsule intact. So again, omega-3 fatty acids or fish oil, this is something that we would expect you to know for our exam, and it's certainly something you might see on the NCLEX. So just a few summary points about the cholesterol medications. First of all, I mentioned that lifestyle modifications are first line, right? So when I say first line, I mean in patients where it's acceptable to try lifestyle modifications without drug therapy, we will do that. It's not always going to work. In many cases, it probably doesn't work. In some cases, the risk for patients is so high that we just start medications. But even when medications are started, we still want to encourage patients, encourage these lifestyle modifications. Of all the drugs that we talked about, statins by far are prescribed the most commonly for reducing cholesterol. You must know these. It's very important to know these well. I mean, you could potentially see any of these on our exam, but I guarantee you we will be asking about the statins. Combination therapy is common, so using a statin with niacin or a statin with a bile acid sequestrant or Zetia especially along with a statin. And this increases the risk for serious adverse effects, namely myopathy or hepatotoxicity. And so in the setting of multiple medications on board, multiple cholesterol medications, extra monitoring is wise. It's really important for these patients to assess their whether or not they're having adverse effects, assess, do they understand how to take the medication appropriately? Really important to be thoughtful of drug-drug interactions. Drug-drug interactions in particular can increase the risk for adverse effects. And so, again, I told you guys early on that, up to half of patients who start a statin stop it within the first year. And in many cases, that's because of adverse effects. And there are things we can do, to prevent patients from experiencing those adverse effects. Namely, one of those is evaluating drug interactions. CAM products. So again, there are some CAM products such as fish oil. Be sure to ask about them when you are collecting a med history for your patients. All right, so case study. So we've got a little case study for our for this particular lecture. And so we've got a 46-year-old female. She's got type 2 diabetes. She's been prescribed simvastatin. Despite good nutrition and exercise, her, resulting in her A1C coming down, her LDL hasn't dropped. And so it's, still pretty high for a patient, especially for a patient with diabetes. That's a, concerning LDL level. So she's going to have to get some she's going to have to get some blood work done, and the doctor is going to prescribe her some cholesterol medication. So I want you all to look through these questions, think about them. If you were in class, we would do what we call think, pair, share. And so in that scenario, you think about the question for a few minutes, maybe 2 or 3 minutes, answer all the different questions to the best of your ability, and then turn to one of your neighbors and kind of talk it through. So I would encourage you guys to do that. Think about it, try to answer these questions, and then maybe pair up with one of your colleagues in the online class and see what they came up with for these questions. We will talk about this particular case study on our next Zoom call. So if you want to hear the answers, definitely log in for that. All right, so thank you for listening. If you have questions about this content, you can post them to the discussion board. Thank you.